Hi, this is Kristen, and I'm going to continue talking about the open educational resource, Human Anatomy and Physiology, Chapter 6. We left off with 6.5, and I just wanted to talk a little bit about how exercise, nutrition, hormones, and inactivity affect bone tissue. So, first of all, if a person were to be completely sedentary or maybe even in space for an extended period of time, they would begin to lose bone mass. In fact, astronauts can lose up to 1 to 2% of their bone mass per month. And so it's important to continually put some sort of mechanical stress on one's bones in order to prevent the loss of bone mineral and collagen fibers. So, obviously, exercise affects bone health. And weight-bearing exercise and resistance training happen to have the greatest impact on bone health. They tend to stimulate the most bone growth and bone strengthening. Any exercise is beneficial, but walking or running or resistance training would be more beneficial to your bones than something like swimming, even though swimming is a great exercise. Um, Nutrition also has a big impact on your bones, and I wanted to just talk real briefly about calcium and vitamin D. So calcium is stored in our teeth and our bones, and it makes up a huge part of the bone in combination with phosphate. That's the primary mineral in our bone. And we can't create our own calcium in our body, so we have to rely on getting it from our diet. In order for us to absorb calcium from our diet, we have to have vitamin D. And we get some vitamin D from our food, although there's not a lot of foods that naturally have vitamin D in them. You can get vitamin D from milk and cereal that's been fortified with vitamin D. Sometimes people take multivitamins with vitamin D, and of course, we can get some from our food. But luckily, we also can make vitamin D, unlike calcium. So the sunlight stimulates a derivative of cholesterol in our skin to be converted into a pre-vitamin D uh, substance. And vitamin D can also be ingested through food and supplements, and it's absorbed by the intestines, and it can be carried to the liver through the bloodstream. Once the vitamin D is in the liver converts it into calcidiol, which is the primary form of the circulating vitamin D, the vitamin D that circulates through our blood vessels. And so the combination of the skin and the liver putting vitamin D into circulation, eventually that vitamin D precursor is going to end up in the kidneys. And in the kidneys, vitamin D is transformed into calcitriol, and that's the actually active form of vitamin D that we use to absorb calcium from our small intestines primarily. So vitamin D also helps us reabsorb calcium in the kidneys as well, rather than being excreted in the urine. So it plays an important role in making sure we have sufficient calcium in our bones. So this is a perfect example of an interaction of different organ systems. We've got the integumentary system interacting with the digestive system, in thinking of the liver, and also interacting with the urinary system, including the kidneys. So we can get vitamin D in fortified milk or cereal. We can also get it in fatty fish like salmon and tuna. And of course, we can get calcium in things like dairy products, green leafy vegetables, broccoli, sardines, salmon, Nuts, beans, and seeds, and shellfish have a little bit of calcium as well. So vitamin K is another important vitamin to mention. I'm going to go ahead and bring up the, let's see, I just wanted to mention some of the other important nutrients other than calcium and vitamin D. So just to reiterate, we absolutely need vitamin D to absorb calcium. And we need calcium in order to make calcium phosphate and calcium carbonate. And those are the primary minerals in hydroxyapatite crystals that give bone its hardness. So calcium phosphate and calcium carbonate is ultimately made from the calcium that we absorb in our diet. Now, vitamin K is another important mineral worth mentioning, or excuse me, vitamin worth mentioning. Vitamin K supports bone mineralization, and they think that it might have a synergistic effect with vitamin D. And basically, a synergistic effect is when two agents have an effect that is greater than the sum of their individual effects. So in other words, vitamin K and vitamin D working together could have a greater effect on bone mineralization than if we were just going to add those two together. They do better working together than they would individually, basically. So vitamin K promotes bone mineralization, and it has a synergistic effect with vitamin D. And then magnesium is another important component of our diet, which is actually a structural component of bone. And fluoride is also a structural component of bone, even though the biggest components are going to be calcium and phosphate. And then omega-3 fatty acids have an indirect effect on bone because omega-3 fatty acids, the types that are found in fish and nuts, reduce inflammation. And it's thought that inflammation interferes with the function of osteoblasts that build new bone. So there's another important part of our diet. Okay, I wanted to talk a little bit about peak bone mass. It's really important that we try to achieve the highest peak bone mass possible. And peak bone mass is just basically the most bone density that a person could achieve in their lifetime. You tend to reach the greatest amount of bone density at about age 30. And after that, we have a steady decline. Now, we can slow the decline and possibly even maintain bone density with a healthy diet and regular exercise. However, there are some genetic factors involved in whether or not we're predisposed to osteoporosis. But basically, in order to prevent a decline in bone mineral density, we want to achieve as high a peak bone mass as possible. And if you look at this image, you'll see that men typically, on average, have a higher peak bone mass at age 30 than do females. And also, females have a tendency to lose bone more quickly. Studies have shown that with regular weight-bearing exercise and healthy diet, that that loss can be slowed, and that maybe it can be more like this as opposed to a drop, a significant drop. If we only get this high with our peak bone mass, then you can see when we lose bone, we're going to be more likely to be in this fracture zone that I'm drawing with these hashed lines. This is the zone when we see a lot of fractures. So the best way to achieve peak bone mass is to make sure that our kids eat healthfully and avoid caffeine and get plenty of exercise. calcium homeostasis. Before I talk about calcium homeostasis, I thought it might be important to mention some of the major hormones that are involved in influencing our bones. So, let's see. I wanted to go ahead and I'll just use this little space right here. And the first thing I want to write down is growth hormone. Growth hormone basically stimulates bone growth. And we have a surge in growth hormone early in life as we're growing, going through childhood and adolescence. But it stimulates bone growth. And specifically, growth hormone increases the length of long bones and it enhances mineralization. So we lay down more hydroxyapatite crystals and it improves our bone density. Now, growth hormone is secreted by the pituitary gland, which is an endocrine gland, and it happens to be found in the skull. Sometimes the pituitary gland is referred to as the hypophysis. And we'll be looking at where this is in the skull very soon because we'll be studying the skeleton. Thyroid hormone, thyroxine, also referred to as T4. There are a couple important thyroid hormones. One is T3 and one is T4. T4 is thyroxine and T3 is triiodothyronine. But thyroxine, which is going to be secreted by the thyroid gland, which is in the cervical region, this also stimulates bone growth and it promotes the synthesis of the bone matrix. Another important hormone that stimulates bone growth are the sex hormones. So the major sex hormone in males is going to be testosterone, and the major sex hormones in females will be estrogens. And these stimulate bone growth specifically by promoting the osteoblast to become more active and to produce bone matrix. Sex hormones are responsible for the adolescent growth spurt, and they also help promote the conversion of the epiphyseal growth plate into the epiphyseal line. So they can be involved in bone growth and also the ending or the ending of the lengthening of bones when they promote the conversion to the epiphyseal line. The sex hormones are thought to work with thyroxine together to promote bone growth. Now, calcitriol, I'm going to write this one up here, calcitriol. Calcitriol is another example of a bone, well, it indirectly stimulates bone growth, and it does that because it stimulates absorption of calcium and phosphate from the digestive tract. And when we absorb calcium and phosphate, we put it into storage in our bones and teeth. And calcitriol is basically vitamin D. That's what we were just talking about. Now, there's one other hormone that has a small effect on bones, and it's called calcitonin. Calcitonin is has an effect in that it inhibits osteoclast activity. So basically it keeps osteoclasts from resorbing bone as rapidly, and it stimulates calcium uptake by the bones. So calcitonin also stimulates bone growth. Now, we said that the growth hormone is secreted by the pituitary gland. Thyroxine is stimulated by the thyroid gland. The sex hormones would be stimulated by the ovaries and the testes. The testes would release or secrete testosterone, and the ovaries would secrete estrogens for females. All right, so those are some important hormones to keep in mind when you're thinking of what stimulates bone growth and an increase in bone mass. Now, let's talk about another hormone which has the opposite effect. Parathyroid hormone. Parathyroid hormone is released by the parathyroid gland. Now, the parathyroid glands are these small bean-shaped glands that are actually on the deep side of the thyroid gland. So the thyroid gland is in the neck, and the parathyroid, well, in that kind of general region, and the parathyroid glands are on the back side of that gland, and they're just little patches of bean-shaped tissue. When they release parathyroid hormone, that hormone, PTH, stimulates osteoclast proliferation. So basically, osteoclasts divide and multiply, and they begin resorbing bone. And it promotes the reabsorption of calcium by the kidney tubules. And it indirectly increases calcium absorption in the small intestine. But the fact that it stimulates the bone resorption is important because it's basically causing the opposite effect of these other hormones I've been mentioning. So I'm going to go ahead and erase all this, and we're going to talk a little bit more about this relationship between parathyroid hormone and bone. Okay, so we have to try to maintain our calcium blood level within a narrow range, and we usually aim for a calcium ion blood level at about 10 milligrams per deciliter, which you can see in this schematic right here. So if we have a sudden say we have a decrease. Well, let's say we have a calcium level increase in our blood. If we have a calcium level increase in our blood, then we will have a tendency to want to put that calcium into the bones in order to try to maintain homeostasis of this approximately 10 milligrams per deciliter of calcium ion in the blood. Now, on the other hand, if we see a drop in calcium ion levels in the blood, we're going to try to increase that level. So let's start over here at the left, and let's say that the thyroid gland releases calcitonin. And that is going to inhibit the activity of the cells that break down bone. It's going to inhibit osteoclasts. There's going to be less bone resorption. And then there's going to be calcium ion reabsorption in the kidneys. So we're essentially reabsorbing calcium in the kidneys, and that's going to be causing a drop in the calcium ion levels back down to normal. If we have a secretion of parathyroid hormone from the parathyroid glands, that hormone is going to travel through the blood to the bones, and it's going to stimulate the osteoclast to break down the bone and release calcium into the blood. So that means that we would have had to initially start with a drop in calcium levels in the blood. That's why our body would have caused the release of parathyroid hormone. And then it caused the osteoclast to resorb the bone, so we have calcium reabsorption. So calcium is coming out of the bone and it's going into the blood. Calcium is being reabsorbed from the urine by the kidneys, so it's being taken out of the urine, what will be the urine, and it's being put into the blood. And then also we're absorbing calcium in the small intestine from our food, and that calcium is also going into the blood. So we're getting all this calcium being put into the blood, and it results in this increase in blood calcium levels. So we see an increase in calcium in the blood. All right, so again, parathyroid hormone is released from the parathyroid gland when there's a drop in calcium levels in the blood. That causes calcium to be resorbed by the osteoclast, put into the blood, and then calcium is taken out of the urine and put into the blood by the kidneys. And then the small intestines are absorbing calcium and putting it into the blood. Therefore, it's a negative feedback loop. We started with a drop in calcium levels and we had an increase in calcium levels. So, on the other hand, let's say that we saw an increase in calcium levels here. So here we see, I don't really like this picture. I want to draw this increase in calcium in the blood because that's actually the stimulus. And then, so this is in the blood, that will cause the thyroid gland to release calcitonin, and calcitonin will inhibit the osteoclast. And so that means that they quit putting calcium into the blood, and then the kidneys stop reabsorbing calcium into the blood. That calcium reabsorption decreases, and as a result, we see a drop in the calcium in the blood. So this is also another negative feedback loop here as well. This is negative and this is negative. And the thing I would change about this picture is that I think the stimulus needs to be before the release of the hormone. And then this little drop in calcium level, technically I should really be writing this right here. And I think it's important to understand the relationship between parathyroid hormone and calcitonin and how they impact blood calcium levels. And why do we care? Because the calcium in the blood is responsible for the things that keep us alive, like transmission of nerve impulses. It's also important for contraction of the heart muscle and contraction of other muscles. And the terms such as hypocalcemia or hypercalcemia would indicate low blood calcium and high blood calcium levels respectively. And so it's more important for our bodies to maintain the homeostatic set point for blood calcium than it is to have it in our bones. So if we don't have enough in our blood, we're definitely going to take it out of our bones, because we've got to ensure that we can convey nerve impulses just to stay alive. Okay, and that's really all I have to say about this chapter. There's a good activity that I posted online that's not required, but It's a good little exercise to go through to help you understand parathyroid hormone and calcium homeostasis. It is right under the outline. It's called Parathyroid Hormone, or PTH, osteoporosis and calcium homeostasis. And there are a few models that you can go through. And I might even do another activity or another little video that kind of takes you through that. But it's something that's not too difficult to do, and I think you could probably get through it yourself. I think it would be an important activity to help you be ready for potential questions on an exam. And if you have any questions, you can always ask me, but it's not a required handout that you have to do. Okay, so I'll go ahead and stop here.